Welcome to the Black Belt Nurse Podcast, where we discuss all things related to violence in healthcare. I'm Bill Schueler, your host, and this is the place where we learn together, mull things over, and generally figure things out. Whether you're a seasoned expert, a student, or just passionate about safety in healthcare, this is the podcast for you. Before we dive in, a quick disclaimer. We do discuss all aspects of violence in healthcare, some of which may be inappropriate for younger listeners and viewers. Please use discretion. The Black Belt Nurse Podcast is for informational and educational purposes only. While we discuss experiences, strategies, and science, this podcast does not provide medical, legal, or professional advice. Always consult your healthcare institution's policies and guidelines or seek professional advice when necessary. And of course, all opinions expressed here are my own and do not represent any employer or organization. Now, let's get started. Hey, amazing listeners and watchers of the Black Belt Nurse Podcast. Love the discussions, insights, and tips from the front lines of safety in healthcare? You can keep this show thriving by supporting us at buymeacoffee.com/blackbeltnurse. Just a small donation helps me bring you more inspiring episodes, expert guests, and practical advice to empower your safety journey. Visit buymeacoffee.com/blackbeltnurse today, and thank you for keeping the Black Belt Nurse Podcast strong. Are you passionate about violence prevention? Are you in the process of researching or writing a paper on a violence prevention topic? Are you on a committee, a task force, or simply interested in exploring the complexities of violence prevention? We're exploring offering access to the Violence Prevention Resource Compendium, which is nearly 100 pages of literature, notes, and links compiled over years and used for our podcast and publications. Would you be interested in accessing it for a small fee? Let me know. Drop a comment or email me at bill@blackbeltnurse.com. Didn't get anything good for Nurses Week? Got someone in your life that you want to show appreciation to? Or maybe you just want to bask in the soft glow of a candle as you decompress from work? This is where Kindness Candles can help. Kindness Candles creates encouragement and light by offering a wide range of stimulating and relaxing scents in an 8.5 ounce 100% soy wax candle. These high-quality candles are also decorated with inspiring words and uplifting graphics. Using our kitchen as a testing center, these candles have gone through hours of testing, resulting in a beautiful candle that smells great and will burn for more than 40 hours. Visit the Kindness Candle store on Etsy at etsy.com/shop/kindnesscandles. That's kindness with a K and candles with a C. Again, that's etsy.com/shop/kindnesscandles. And now, on to this episode of the Black Belt Nurse Podcast. On February 18th, 2025, a nurse was severely attacked at the HCA Florida Palms West Hospital. The attack was so severe that the news reported that the attacker broke essentially every bone in the nurse's face and that she might lose her eyesight. In the response to the media, the hospital CEO said that the hospital has a zero-tolerance policy towards workplace violence. The CEO also went on to say that a regulatory agency had visited the facility and had not recommended any immediate corrections to the operation. And their own internal review found that all procedures and policies were followed. In March of 2023, a nurse was attacked with a base plate from a thermometer, leaving him needing 3 stitches in his face. In their response to the media, TriStar Centennial Medical Center said, "The safety and security of our patients, physicians, staff, and visitors is of utmost importance. TriStar Centennial Medical Center has policies, processes, and protocols in place to maintain a safe environment. We have a zero tolerance for harassment of any kind in our hospital, and when necessary, will take appropriate action, which may include contacting law enforcement to ensure a safe and healthy environment for all." In July of 2023, a security officer was killed outside a labor and delivery unit at Legacy Good Samaritan Hospital in Portland, Oregon. The perpetrator had been visiting the hospital for multiple days before the shooting and had demonstrated aggressive behavior multiple times. In a news article, it was mentioned that Legacy Health does have a zero tolerance policy for aggression, but the final call to remove someone from the hospital can vary depending on which manager is on the clock. And in their comments to the media, the health system said safety is our top priority. A resulting $35 million lawsuit against the hospital claims that despite the hospital having zero tolerance for weapons, they took woefully inadequate measures to ensure that the hospital was free from weapons. A 35-year-old male presented to the emergency department for chest pain, accompanied by his girlfriend. He asked to see a physician and became belligerent when a nurse asked him why. He was escorted out by security. Several minutes later, his girlfriend came back saying that he had suffered a seizure and was in her truck. The staff refused to get the patient out of the truck. The girlfriend took him to another hospital where he was pronounced dead. At the same hospital, a 24-year-old male reported to the emergency department complaining of weakness and he had altered mental status. He was reported as aggressive and non-compliant. As he was leaving, he collapsed. A security officer put him in a wheelchair and wheeled the patient off hospital property where he was left on the ground. He was found 4 hours later, cold and with decreased responsiveness. He was transferred to another hospital where he died 2 weeks later. The hospital ended up settling with the Office of the Inspector General for $80,000 for the EMTALA violations for failure to screen for an emergency medical condition. As mentioned in these news stories, zero tolerance is a common feature in violence prevention policies throughout healthcare in the U.S. You often hear, "We have zero tolerance for violence." But what is zero tolerance? What does it mean? Let's start with a couple definitions. Merriam-Webster Dictionary defines zero tolerance as a policy of giving the most severe punishment possible to every person who commits a crime or breaks a rule. The Cambridge Dictionary defines it as the act of punishing all criminal or unacceptable behavior severely, even if it is not very serious. The American Heritage Dictionary defines it as a law, policy, or practice that provides for the imposition of severe penalties for a prescribed offense or behavior without making exceptions for extenuating circumstances. And lastly, Wikipedia defines it as a policy which imposes a punishment for every infraction of a stated rule. Zero tolerance policies forbid people in positions of authority from exercising discretion or changing punishments to fit the circumstances subjectively. They are required to impose a predetermined punishment regardless of individual culpability, extenuating circumstances, or history. This predetermined punishment, whether mild or severe, is always meted out. How did we get to the point of using zero tolerance in healthcare violence prevention? My findings indicate that zero tolerance policies in healthcare started sometime in the late 90s, likely with the National Health Service in the UK in 1999. It also seems that the United States later adopted this philosophy starting sometime in 2008 with the Joint Commission, but that was mostly directed towards healthcare worker behavior. The broken windows theory is also mentioned in healthcare literature. It was introduced in 1982, and it suggests that visible signs of disorder in society, such as broken windows, can lead to further crime if it's not addressed. The broken windows theory, which is a concept of zero tolerance, was popular in law enforcement and education first, with subsequent influence on the healthcare industry. There is discussion that the broken windows theory has some influence on zero tolerance policies in healthcare. However, the broken windows theory has not been found to be directly the cause of zero tolerance policies in healthcare. Think of them as close cousins who influence each other. But there's more to the history of zero tolerance coming up next in the review of the scientific literature. So let's take some time to look at some papers surrounding zero tolerance in the healthcare sector. Our first paper is from Sugrue in 2003 titled Zero Tolerance for Children, Two Wrongs Do Not Make a Right. In this paper, the author talks about the history of zero tolerance starting in the war against drugs in the 1980s, and it was popularized in the U.S. Customs Service and then became a part of the public policy directives. And then, unfortunately, after some criticism, threats of lawsuits, and embarrassing incidents, U.S. Customs began to withdraw from their stringent enforcement of zero tolerance policies. But by then, a few public school districts had embraced zero tolerance, and then that flowed into the federal Gun-Free Schools Act of 1994. That legislation told states that they had to, 1, have legislation that expelled students for at least 1 year for bringing a firearm to school. 2, schools were obligated to refer these students to the criminal justice system. And 3, state law could allow that an administrator could modify the expulsion on a case-by-case basis. And lastly, 4, they had to report these statistics to the federal government. So when the states made these laws, there was lots of variation, some including fights and verbal abuse and possession of alcohol or tobacco, and even chronic tardiness as part of their zero tolerance policy. The author states that the zero tolerance policies can usurp professional judgment of school administrators with little consideration to individual circumstances, and as well as lack of being able to teach children about fairness, justice, and common sense. There's a concern for overreach and over-inclusiveness to treat criminal acts and misbehavior as equally offensive. So even back then, there was a concern with zero tolerance policies creating issues with due process, civil rights, and other constitutional guarantees, as well as depriving affected students of education. And even then, there was little evidence that zero tolerance policies had brought security and safety to schools. The next paper is from 2005 from Duxbury and Whittington, titled Causes and Management of Patient Aggression and Violence, Staff and Patient Perspectives. The researchers noted that zero tolerance policies can exacerbate issues by placing blame on patients and fostering intolerance among caregivers. Next is from 2006 from Wand and Colson, titled Zero Tolerance, A Policy in Conflict with Current Opinion on Aggression and Violence Management in Healthcare. They mentioned that the concept of zero tolerance originated in the U.S. with the Gun-Free Schools Act of 1994, which again required zero tolerance for bringing guns to schools with automatic expulsion of students for a period of 1 year if they violated the rule. They said that the UK and New Zealand followed suit with zero tolerance, and Australia seemed to adopt it as well within the healthcare sector. The authors mentioned that while it can be a neat political slogan, zero tolerance can disturb the balance in deciding what is acceptable behavior in certain circumstances. Zero tolerance can restrict the clinician's decision-making. They talk about the factors that influence the likelihood of violence, which includes impulse control, the ability or inability to verbalize feelings and problems, the level of empathy for a potential victim, and the ability to be persuaded that injuring another person is wrong. They also highlighted situational factors such as noisy environments, unknown people, limited space, as well as crowding. They also highlight that zero tolerance for aggression and violence in the emergency department is largely impractical. They also highlight that the key attributes to managing violence and aggression include strong interpersonal skills to diffuse situations that include willingness to listen, negotiate, and problem solve. They also encourage proficiency in early recognition, de-escalation, and safe restraint taught through practical and continuing training and education. They said funding should be for education and training rather than misleading political rhetoric such as zero tolerance. Next, we have a paper from Paniagua, Bond, and Thompson from 2009, and their paper is titled Providing an Alternative to Zero Tolerance Policies. The authors say that the consequences of applying zero tolerance policies can be far-reaching and with significant ethical problems. Uncompromising zero tolerance could lead to abuse of a person's entitlement to show appropriate anger and frustration, and that inflexibility can lead to unfair punishment. They mention that some programs take the view that it is the staff member who needs to take the initiative to reduce incidents of violent behavior, but they say the evidence indicate it increases incidence of aggressive behaviors. They also highlight that impoverished and the disadvantaged can be more likely to be punished by zero tolerance than others. Blanket application of zero tolerance is not always effective because it can be unclear what is considered aggressive behavior. Next is a paper from Copeland and Henry from 2017 titled Workplace Violence and Perceptions of Safety Among Emergency Department Staff Members, Experiences, Expectations, Tolerance, Reporting, and Recommendations. They reported that 88% of emergency department workers reported exposure to violence within the past 6 months. 64% of those in the survey agreed with the statement that verbal and physical violence is an expected part of the job, and those who agreed had a higher level of tolerance to violence. Regarding zero tolerance policies, they talk about that it is unethical to refuse treatment, and we cannot turn people away even if their behavior is out of control. Quote, zero tolerance is not an option. We tolerate out-of-control behavior to provide emergent medical care, unquote. Zero tolerance policies might not have an influence on violent patients, but they could for family and visitors since they can be removed. Zero tolerance policies haven't been shown to prevent violence, and they don't come into effect until after the violent incident has occurred, and then they are dealt with per policy. They also recommend that the policies should focus on risk assessment and resource allocation rather than zero tolerance. Focusing communication on behavioral expectations may be more beneficial to articulate policy and hold accountable those with the capacity to understand the policy. Next is a paper from Morfett et al. From 2018 titled Prevention and Management of Occupational Violence and Aggression in Healthcare, a scoping review. The authors reviewed 20 studies focusing solely on healthcare. There's no evidence to support duress alarms, incident reporting, or even zero tolerance policies. And they also mentioned that zero tolerance policies fail to differentiate between the different types of violence. The next paper is from Beatty et al. Titled Workplace Violence, Examination of Tensions Between Duty of Care, Worker Safety, and Zero Tolerance, published in 2020. The authors mentioned zero tolerance originated in the U.S. in response to community crime, starting with the broken windows theory by Wilson and Kelling in 1982. And the broken windows theory offers zero tolerance to minor offenses as a way of preventing major crime. The next paper is from Beatty et al. Titled Workplace Violence, Examination of Tensions Between Duty of Care, Worker Safety, and Zero Tolerance, published in 2020. The authors mentioned zero tolerance originated in the U.S. in response to community crime, starting with the broken windows theory by Wilson and Kelling in 1982. And the broken windows theory offers zero tolerance to minor offenses as a way of preventing major crime. Applied to healthcare, zero tolerance requires an immediate response to all incidences, no matter how seemingly minor. Zero tolerance has become accepted internationally as a mechanism to decrease workplace violence. However, from their literature review, there's no evidence to support that it actually does decrease workplace violence. The authors found a theme of a tension between the duty of care and maintaining safety. They highlight that you cannot refuse patients. Complex, vulnerable patients include those with dementia, delirium, drug-affected patients, and mental health patients. Caregivers felt obliged to provide clinical care and, on the other hand, obliged to maintain a safe workplace. But you cannot actually do both. While caregivers prefer de-escalation, sometimes they have to use physical or chemical restraint. The next theme is the tension between duty of care and zero tolerance. They include that policies can increase duty of care tensions. Caregivers support the notion they cannot refuse to treat people, and regardless of zero tolerance policy, they carry out the duty of care. Zero tolerance can empower staff to call for help and act as a warning to patients and visitors with including signage. Caregivers are prepared to care for confused patients, those not in control of their actions, those who are under the influence of drugs or experiencing psychosis or dementia, but they did not tolerate aggression for other reasons like frustration with wait times. There's contrasting views about the merits of zero tolerance, and they found that zero tolerance was rarely enacted because staff didn't feel they could refuse treatment. So now we have this incongruence between the different acts and regulations and guidance materials related to workplace violence. They highlight that although there is support for the concept of zero tolerance, enacting zero tolerance is an ethical challenge in that it does not discriminate between different causes and triggers. It doesn't consider that signage could be a possible trigger. It doesn't consider the threat of an actual ejection can be considered aggressive itself. And it doesn't consider the question of could zero tolerance itself trigger aggression and violence in healthcare. There seems to be a lack of definition of what is aggressive or violent behavior. Like, is what the dementia patient demonstrates violence or aggression versus somebody who's frustrated with wait times? Is that aggression or violent behavior? They also propose that caregivers receiving training on zero tolerance were more rigid, less tolerant, less confident, and less skilled. At the end of their study, they highlighted from the 2008 study that following a review of the adoption of zero tolerance by the National Health Service in the United Kingdom, and this study was by Patterson et al. In 2008, they concluded that zero tolerance was essentially violent in of itself and should be rejected as inappropriate as it was already the case in England. Next is a 2020 study from Ellis et al. Titled An Empirical Application of Broken Windows and Related Theories in Healthcare, Examining Disorder, Patient Safety, Staff Outcomes, and Collective Efficacy in Hospitals. The authors discussed applying the neighborhood disorder concept in healthcare, mentioning the broken windows theory from Wilson and Kelling from 1982, which talked about physical disorder, which is noisy, dirty, run-down physical space, as well as social disorder, like hanging around, drinking, using drugs, bullying, and using violence. And that signals that kinds of negative actions are normalized and tolerated, which can then fuel more incivility and more serious crime. And those signals that negative actions can be normalized and tolerated, which can then fuel more incivility and more serious crime. So the broken windows theory contributed to zero tolerance policing as well as stop and frisk programs, and the goal was to pay attention to the minor offenses in order to prevent more serious offenses. The authors studied hospital disorder related to staff burnout, job satisfaction, and patient safety. They found that both physical disorder and social disorder were significantly associated with higher burnout and lower job satisfaction, and both were associated with lower levels of patient safety. Overall, workplace disorder is a marker for poorer workplace culture. Staff must work together to pick up the slack to avoid serious threats to safety and quality of care, but staff are not responsible for the physical disorder. That's the organization's responsibility. Next is a 2021 paper by Davids et al. Titled Exploring Staff Experiences, a Case for Redesigning the Response to Aggression and Violence in the Emergency Department. The authors interviewed staff regarding Code Black events, which are responses to aggression and violence. They found that staff were unclear when to activate a Code Black, which was influenced by a culture where staff tolerate abuse despite a zero-tolerance policy. There was inconsistency of applying policy due to work demands and culture, including time pressures and acceptance of violence as part of the job. A 2021 paper by Stand et al. Titled Zero Tolerance Starts Now, Making Nurses' Safety a Priority, reviews the American Nurses Association calling for zero tolerance within nursing and for consequences for breaking policy. The authors also reviewed AACN's Critical Care Nurse Work Environment Survey from 2018, which reported that hospitals which had zero-tolerance policies reported fewer negative incidents than those without zero-tolerance policies. There was a recommendation that leaders invest in a no-tolerance campaign with education involving staff, patients, and families. Fan et al. Published a paper in 2021 titled Rethinking Zero Tolerance, a moderated mediation model of mental resilience and coping strategies in workplace violence and nurses' mental health. They highlight Copeland and Henry's 2018 paper, which noted that zero tolerance may not be helpful for the mental health of healthcare workers, as those with higher tolerance for workplace violence had better mental resilience and better psychological well-being. Esposito and Solasso's 2021 paper titled A Time-Limited Look at Whether the New York State Felony D Law or Workplace Violence Programs Mitigate Violence Against Nurses in the Healthcare Setting. This study posits that zero tolerance is an insufficient approach that needs to evolve to a more progressive approach of zero incidents, which focuses on the elimination of at-risk behaviors before an incident occurs. They cite a U.S. Supreme Court case, Farragher versus City of Boca Raton, highlighting that companies must prevent, not simply react to, a hostile workplace. They cite a U.S. Supreme Court case, Farragher versus City of Boca Raton, highlighting that companies must prevent, not simply react to a hostile workplace. The authors also note that nurses often end up in a conflicted situation. They have to decide if they're going to protect themselves or their patients in violent situations. Some nurses who become victims and fight back are accused by their employers of doing something wrong. Spelton et al.'s 2022 paper, Workplace Violence Against Emergency Healthcare Workers, What Strategies Do Workers Use?, stated that zero tolerance for threats without actual follow-up could encourage people to push the boundaries of what is acceptable behavior. It's really about the lack of action. A 2023 paper by Feaster and Yuan in the American Journal of Bioethics talks about behavior contracts. Behavior contracts could be considered a tool that supports zero tolerance policies. Behavior contracts were introduced in the mid-1960s and early 1970s, mostly in outpatient mental health. Contracts have migrated into the management of interpersonal conduct of patients and family members with their interactions with clinical staff. The goal is to manage behaviors. A criticism of behavior contracts is there's little accountability or behavior parameters that are placed on the conduct of caregivers. The contracts operate under the assumption that caregivers never act badly or unprofessional. They could be considered an unconscionable contract, which violate a legitimate contract because they are extremely one-sided. Behavioral contracts also lump all undesirable behaviors together. There should be a threshold of offensiveness, such as a perceived physical threat demands the strongest protective response. Behavioral contracts demand unreasonable decorum within the context of medical care. Demanding excellent manners seems morally inappropriate in the hospital setting, as hospitals are not a typical social setting. Going to the hospital is often not elective. Often it is life and death, and hospitals don't have the prerogative to decide who they treat. It can trivialize the emotions of patients and families, which can include despair, hopelessness, agony, loss, fear, uncertainty, and anxiety. Behavioral contracts are psychologically naive about the causes and remedies of maladaptive behavior. They view the behavior as the thing in itself and not a symptom of a problem. Getting to the source of disruptive behavior is the core of conflict management, clarifying the root cause. Behavioral contracts are coercive. There is an illusion of choice. It can be holding medical care as a bargaining chip to force compliance. And lastly, behavioral contracts violate the principle of treating cases alike. Hospitals pick and choose who will have a behavioral contract imposed on them, and it can't be done in a fair and justified manner. Even perpetrators of heinous crimes still have a legal right to health care. The arguments are less compelling for family members who are disruptive. The treatment team's responsibility is to the patient. Arguments against this is family-centered care. Behavioral contracts are justified because they are what the care team turns to when there are no other viable actions. The contract is a tool of the desperate, but there can be a lack of familiarity with everything possible, and it more likely means everything they know how to do. What is required is conflict management or mediation skills. Having highly trained expert mediators on staff can be an asset, as well as trained clinical staff. Rozelle's 2023 opinion paper in the American Journal of Bioethics highlights that zero tolerance policies are concerning for medical ethics and security operations as they are ineffective and unethical. Each case of agitated patient or visitor behavior needs individualized assessment and intervention. Behavior contracts can help with this. Not all disruptive behavior occurs in the context of a crisis. It should be presumed to be driven by a behavioral or clinical emergency until proven otherwise. Perhaps the use of the term safety plan could be more fitting than behavior contract. Fraganovich et al.'s 2024 paper used the AACN's Critical Care Nurse Work Environment Survey for over 1,000 critical care nurses in 5 European countries. Only 42% had zero tolerance policy for physical abuse, and 28% had a policy for verbal violence. Organizations that had a zero tolerance policy for physical abuse rated better communication between nurses and unit nurse managers and hospital administration. Having a zero tolerance policy for physical abuse considered collaboration between nurses and physicians as excellent. They considered respect for nurses as excellent and better respect by physicians, administration, other healthcare colleagues, and unit nurse managers. Having a zero tolerance policy was associated with nurses rating unit nurse managers better. Miller and Squire's 2025 paper mentions that zero tolerance can decrease visitor violence, but does not seem to have a significant impact on violence perpetrated by patients. And lastly, Copeland et al.'s 2025 paper titled Nurses' Perceptions of Patient Violence, Exposure, Risk Factors, and Risk Tolerance mentions zero tolerance policies have zero evidence they are effective. Zero tolerance policies are associated with rigid staff attitudes and can increase violence. They are difficult to implement as caregivers prioritize their duty to care as their highest priority. Tolerating psychological violence has resulted in better health outcomes compared to intolerance. So the literature seems to have quite a bit to say about zero tolerance policies. What are some positive aspects of zero tolerance? Well, they can help define and set the expectation for appropriate behavior, not only for patients, but for visitors, family members, and even staff. They can enact a response and possible consequences for unacceptable behavior. They set a behavior standard. They seem to be appropriate for people who are aware of their behavior, especially family members and visitors. They can encourage calling for help and reporting violent incidents by caregivers. And according to some surveys, they can possibly influence less violence. So, what are some negative aspects of zero tolerance policies? Well, zero tolerance has a very sketchy history in law enforcement and public education prior to appearing in the healthcare sector. There's a lack of defining what version of zero tolerance hospitals are following. There's a lack of clarity if the zero tolerance policy applies to those who intentionally, knowingly, or recklessly commit violence versus those who don't know. Zero tolerance policies can contribute to a failure to plan for violent or aggressive patients or visitors or staff. They can contribute to an attitude of, that won't happen here. Zero tolerance policies assume people are able to comprehend that policy as well as control their behavior. It can tend to be viewed as a black and white policy that doesn't allow for the many shades of gray, such as people in pain, people who received a poor prognosis, those unfamiliar with their surroundings, or maybe they're under the influence of medications or drugs, or just their disease process. Zero tolerance is antithetical to when violence is appropriate, such as in incidents of self-defense. The policy can then wrongfully be used to discipline or terminate a caregiver for using justified and legal force to stop. Zero tolerance creates a problem when violence is appropriate, such as incidents of self-defense. The policy can wrongfully discipline or terminate a caregiver for using justified and legal force to stop great bodily harm or death. There is the rare occasion when violence is an appropriate response. The policy can put institutions at risk for regulatory and legal repercussions due to a lack of due process, thoughtful investigation, and seeking explanation of actions. Damage to the institution's reputation can negatively affect the public's perception, as well as hamper recruitment and retention. Healthcare workers do not believe zero is achievable, and they expect some violence. Zero tolerance creates a care paradox. This is when the caregivers want to care and they know that they should care for a patient, yet over here there's a policy that says we have zero tolerance. It is not acceptable. You need to apply consequence. Zero tolerance can't be enforced with our current laws and regulations, such as EMTALA. EMTALA stands for the Emergency Medical Treatment and Active Labor Act, and this came into being in 1986. It's also referred to as the anti-dumping law. It means that an emergency department cannot turn somebody away due to their inability to pay or because they are in labor. My opinion, well, remember at the beginning where I read you some news stories, and these are significant violent events that happen. And in the media, the hospitals or health systems will say safety is our top priority, or we have a zero tolerance for violence. Well, as you can see, yes, they do have that in their policy, but it still happens. And some of it is pretty severe. And also some patients were agitated or violent or aggressive and then get kicked out. They don't get the appropriate care and they suffer a bad outcome. And that's truly taking zero tolerance and applying it inappropriately to where people suffer and die from it. Zero tolerance policies can be considered just empty words. Healthcare cannot have zero tolerance for violence or aggressive behavior, as there are many, many reasons why a person may be violent. And this is covered in the first 3 episodes of the podcast, where we started to answer the question, is violence part of the job? So I encourage you to go back and listen to those first 3 episodes. And science clearly shows that zero tolerance creates a dilemma for caregivers who understand the disease process, and yet they want to care for patients even if they are aggressive. Healthcare is not, nor should it be, in the business of punishing people, especially if they are in the middle of a medical or a psychiatric crisis. Healthcare touts zero tolerance, but seems to act in a pretty hypocritical way. And zero is impossible to achieve. Anything with a goal of zero, there's lots of criticism for that, and includes it's not being based in reality, it can be considered cultish, and they just can be considered empty words. Regardless of a zero tolerance policy, significant violent events aren't a matter of if, they are just a matter of when. And we have over 20 years of literature that recommends against zero tolerance policies. So what can be the way forward? There's some sage advice that comes from a 2019 book called Workplace Violence, Issues and Threat Management. And they say, quote, use caution when including terminology such as zero tolerance in your policy. Zero tolerance puts your company in the position of acting on every allegation that is made and imposing automatic discipline even if there is no merit to the allegation. Zero tolerance policies do not allow your company to exercise discretion or change direction to fit the facts and circumstances surrounding the incident. They are designed to impose a predetermined discipline regardless of individual culpability, their circumstances, or past history. Instead of using the terminology zero tolerance, it might be better to state all incidents are taken seriously and are thoroughly investigated. This will allow your company to assess the facts and circumstances on a case-by-case basis and then determine the best course of action and appropriate corrective action. Additional strategies could focus on a proactive approach to violence prevention, such as violence prevention programs, education, violent risk assessment tools, and robust communication of violence risk or violent behavior. Those violence risk assessment tools can have predictive value and then preventative interventions can be considered to decrease that risk of violence. Another strategy could be to survey your caregivers. Ask them what their attitudes are on what contributes or causes violence. Ask them what works or doesn't work. Ask them directly if they believe that zero tolerance is appropriate, or even if the hospital can achieve zero tolerance. You could also ensure that your policy is prescriptive in how it addresses violence. A violence prevention policy should include very specific definitions of violence. Are you going to include sexual violence in there? Are you going to include bullying? Perhaps your policy should also include differentiation between intentional versus unintentional violence. So in summary, zero tolerance policies in healthcare aim to address workplace violence by imposing severe penalties for any infraction, but they face significant challenges. They are not enforceable, not proven to decrease violence, they create ethical issues, and they can create more problems than they solve. Healthcare institutions should steer away from using zero tolerance concepts, as it is nearly impossible to achieve zero, and that is due to the patient populations we serve, as well as the current ethics and federal regulations that demand that we should and we must take care of people, even when they are agitated, aggressive, and violent. That's a wrap for this episode of the Black Belt Nurse Podcast. If you enjoyed this episode, don't forget to like, subscribe, and hit that notification bell so you never miss a new episode. Drop a comment below and let me know your biggest takeaway. I would love to hear from you. You can find me on LinkedIn and Facebook, as well as blackbeltnurse.com. For now, be safe, and I'll see you in the next episode.